السلام عليكم. محاضرة اليوم عن normal labor. Objective of this lecture: at the end of this lecture you will be able to diagnose labor and define the stages, assess a laboring patient, filling a partogram, understand the cardinal movement of labor and delivery, which is initially long, fair, and closed with a protective mucus plug, must shorten, thin out, effacement, and dilate for labor to progress. The uterus must change from a state of relaxation to an active state of regular, strong, frequent contractions to facilitate transit of the fetus through the birth canal. Each contraction must be followed by facilitate transit of the fetus through the birth canal. Each contraction must be followed by a resting phase in order to maintain placental blood flow and adequate perfusion of the fetus. Described in terms of frequency within a 10-minute. Daily duration also varies during labor from 30 to 60 seconds. Diagnosis of labor: the presence of strong, regular, painful contractions resulting in progressive cervical changes, effacement, and dilatation of the cervix. Loss of show, blood-stained plug of mucus passed from the cervix, or spontaneous rupture of the membranes does not define the onset of labor, although these events may occur around the same time. Here, as you see, onset of labor. At the end of pregnancy, estrogen, more than progesterone, comes from the endometrium of the uterus, lead to what increase in prostaglandins, prostaglandin E2 and F2 alpha. This lead to what? Two mechanisms. First mechanism, increase in calcium, which lead to uterine contractions become more forceful, and ripening of the cervix. So, ripening of the cervix occurs by what? By reduction in the collagen production and increase in glycosamine glycogen fibers and glycosamine glycogen fibers and coil. When calcium is increased here, affect the myometrium of the uterus, lead to shorten in the body of the uterus. Contraction pushes the fetus head down. Both of these two mechanisms lead to what? Lead to cervix stretches. This leads to a Ferguson reflex, which what? Act on the hypothalamus, then posterior pituitary, lead to what? To increase in oxytocin production, also act on what? On the uterine, increase in uterine contraction become more frequent and return to act on the uterus, and so what? Okay, the same, like that. Pelvis. This is the gynecoid pelvis, platyploid pelvis, android pelvis like heart shape, anthropoid pelvis. This is the bone ilium, anterior superior iliac spine, symphysis pubis, ischial spine, which is very important landmark, Here also, as you see, this is the ischial spine. Find what? The distance between the two ischial spines by the fist of the hand. Here the diameters. Here the obstetrical diameter 10.5, telspinous 10 cm, transverse 13.5, this is of the inlet, transverse 13.5, this is of the inlet, transverse of the inlet. This is the anus, vagina, the muscles, skull, occipital bone, lambdoid suture, posterior fontanelle, parietal bone, sagittal suture, anterior fontanelle, coronal suture, frontal bone, frontal suture, frontal suture. Also there is here dimensions of the fetal skull. This is the sensipod. This all the vertex. This is the occiput. Lambdoid suture, occipital bone, temporal suture, the Leopold maneuver, as you know. This is the lateral grip, pelvic grip, two types of pelvic here to see what occupying the grip. Two types of pelvic here to see what occupying the lower segment, and this also the pelvic grip to see if there is any engagement or not in the presenting part. About stages of labor. From the onset of labor to complete cervical dilatation, divided into latent and active. Latent, from the time between the onset of regular painful contractions and the 3 to 4 cm cervical dilatation, which is lasts between 3 to 8 hours, being shorter in multiparous women. Active, first stage of labor, from the time between the end of latent phase 3 to 4 cm dilatation and full cervical dilatation 4 cm dilatation and full cervical dilatation 10 cm, lasting between 2 and 6 hours, shorter in multiparous women. Cervical dilatation during the active phase occurs typically at 1 cm per hour or more in a normal, but is only considered abnormal if it is occurred at less than 1 cm in 2 hours. Less than 1 cm in 2 hours considered abnormal. Second stage of 1 or 2 hours is usually recommended to allow the head to rotate and descend prior to the active pushing. Active second stage. Active second stage should last no more than 2 hours in nilliparous and 1 hour in multiparous. Use of epidural anesthesia will in multiparous. Use of epidural anesthesia will influence the length and management of the second stage of labor. Third stage. This is the time from delivery of the fetus or fetuses until complete delivery of the placenta or placental and membranes. The placenta is usually delivered within a few minutes of birth of the baby. A third stage lasting more than 30 minutes is defined as abnormal. Prolonged labor, but it would be reasonable to suggest that labor lasting longer than 12 hours in nulliparous women and 8 hours in multiparous women should be regarded as prolonged. 8 hours in multiparous women should be regarded as prolonged. Precipitous labor is defined as expulsion of the fetus within less than 3 hours of the onset of regular contractions. Here, as you see, stage 1, latent phase. Cervix is closed. This is the fetus. Active phase, the cervix begins to be dilated and effaced. Second stage, fully cervical dilatation and the crowning of the head. Third stage, delivery of placenta and membrane. So here is the stages of labor. Time per hour and cervical dilatation per centimeter and contractions. We have important definitions. Presentation: the part that lies closest to the pelvic inlet, called presentation. Attitude: relationship of fetal parts to each other, flexion or extension. Lie: relationship between longitudinal axis of the fetus to that of mother. Position: relationship between fetal denominator and the vertical and horizontal between fetal denominator and the vertical and horizontal planes of the birth canal. Here, as you see, the head is well flexed, less flexed, deflexed, extended. For each presentation, transverse lie, also here transverse lie. Cephalic presentation, here occiput. This is also the occiput, are called face to pubis. Here this is called deep transverse arrest. Series of changes in position and attitude that the fetus undergoes during its passage through the birth canal. Engagement: when the widest part of the presenting part has passed successfully through the pelvic inlet. In nulliparous women prior to labor, the number of fifths of the fetal head palpable abdominally is used to describe whenever engagement has taken place. If more than 2/5 of the fetal head is palpable abdominally, the head is not yet engaged. Descent is needed before flexion, internal rotation, and is needed before flexion, internal rotation and extension. First stage and passive second stage of labor as a result of uterine contraction, and in the active phase of the second stage of labor by the voluntary efforts of the mother. We said the rule of fifth. We divided the fetal head into fifth parts. Here, completely above the pelvic brim. The head is completely above the pelvic brim. Now, 4/5 above the pelvic brim and 1/5 below. 3/5 above the pelvic brim and 2/5 below. 2/5 above the pelvic brim and 2/5 above the pelvic brim and 3/5 below. That's now engaged. Now the head is engaged. 1/5 above and completely engaged. So no head is palpable abdominally. Fetal head flexed when it enters the pelvis. It is important in reducing the presenting diameter of the fetal head. Internal rotation. If the head is well flexed, the occiput will be the leading point, and on reaching the sloping gutter of the levator ani muscles, it will be encouraged to rotate anteriorly, so that the sagittal suture now lies in the anterior-posterior diameter of the pelvic outlet. The anterior-posterior diameter of the pelvic outlet, which is the widest diameter. Extension. Now the occiput is beneath the symphysis pubis. Then the head extends and the occiput escape from the underneath the symphysis pubis and distends the vulva. This is known as crowning of the fetal head. Face and chin appear in succession over the posterior vaginal opening and perineal body. Restitution. The slight rotation of the occiput through 1/8 of the circle is called restitution. As soon as the head crosses the perineum, it aligns itself. The head crosses the perineum, it aligns itself with the shoulders, which have entered the pelvis in the oblique position. Now the head is floating as you see before engagement. Now the head is engaged. Look to the occiput in relation to the symphysis pubis. Further descent of the fetal head and internal rotation. Look to the occiput. Complete rotation, the occiput beneath the symphysis pubis. Complete rotation, the occiput beneath the symphysis pubis. And beginning of what? Of extension. External rotation. In order to be delivered, the shoulders have to rotate into the direct AP plane. Remember the widest diameter at the outlet. When this occurs, the occiput rotates through a further 1/8 of the circle to the transverse position, and this is called external rotation. Delivery of shoulders and fetal body. The anterior shoulder is under the symphysis pubis and delivers first. The posterior shoulder delivers subsequently. Traction is often exerted by gentle pulling the fetal head in a downward direction, helping the fetal head in a downward direction help release the anterior shoulder from beneath the pubic symphysis. Here, as you see, complete extension, then restitution, external rotation, the fetal face what's internal thigh, delivery of anterior shoulder from beneath the symphysis pubis by gentle pulling of the head downward, then delivery of the posterior shoulder by gentle pulling of the fetal head upward. Here you see downward, then upward. Here you see downward, then upward, with the direction of what? Of the birth canal. The direction of the birth canal. The admission, history, and examination provide an initial screen for abnormal labor and increase maternal or fetal risk. Admission history: previous birth and size of previous babies, previous cesarean section, onset, frequently duration, and perception strength of the contraction, whether membranes have ruptured, and if so, color, whether membranes have ruptured, and if so, color and amount of amniotic fluid lost, presence of abnormal vaginal discharge or bleeding, recent activity of the fetus, fetal movement, medical or obstetrical issues of note, example, diabetes, hypertension, fetal growth restriction. Any special requirement as interpreter or particular emotional psychological needs. General examination, body mass index, as this may complicate the management of labor. Temperature, pulse, blood pressure must be recorded, and sample of urine tested for protein, blood, ketones, glucose, nitrate. Abdominal examination, inspection, 0-point maneuver to assess LI of the fetus, presenting part, the degree of engagement, assessment of the uterine contractions. Vaginal examination, assessment of cervical dilatation, cervical effacement, the fetal head, position, station, attitude, and the presence of caput or molding. Women in labor should have pulse measured hourly, temperature and blood pressure every 4 hours. Frequency of contractions should be recorded every 30 minutes. Frequency of contractions should be recorded every 30 minutes. While in the second stage, blood pressure and pulse performed hourly. Vaginal examinations offered every hour. Assessment options in labor. Inspection of amniotic fluid. Fresh meconium staining, absence of fluid, heavy blood-stained fluid, or bleeding are markers of potential fetal compromise. Intermittent auscultation of the fetal heart using a Pinard stethoscope or handled Doppler ultrasound. Continuous external electronic fetal monitoring using CTG. Continuous internal electronic fetal monitoring using fetal. continuous internal electronic fetal monitoring using fetal scalp electrode, fetal scalp blood sampling, at least 1 minute immediately after a contraction. This should be repeated every 15 minutes during the first stage of labor, and at least every 5 minutes in the second stage of labor. Indications for continuous fetal monitoring: significant meconium staining of the amniotic fluid, abnormal fetal heart rate detected by intermittent auscultation, maternal pyrexia, fresh vaginal bleeding, augmentation of contraction with an oxytocin infusion, maternal request. Here in this picture you see the descent of the head and the rule of 5. This is the ischial spine. Molding of the fetal skull bones. Letter I. If ruptured membrane and clear liquor, C. If ruptured membranes and conium, C. If ruptured membranes and conium stained liquor, M. Ruptured membranes blood stained, B. Ruptured membranes and absent liquor, A. Of the fetal skull bones. Molding is an important indication of how adequately the pelvis can accommodate the fetal skull. Increasing molding with the head high in the pelvis is an ominous sign of cephalopelvic disproportion. If the bones are separated, and suture felt easily, this is 0, there is no molding. If the bones just touch each other, 1 plus molding. If the bones overlapping, but it is molding. If the bones overlapping, but it is reducible, reducible by our finger, +2. If severely overlapping bones and non-reducible, this is +3. This part 2 for the progress of labor. Descent of the fetal head, uterine contraction. Part 3 for the maternal condition. Assess maternal condition regularly by monitoring drugs, IV fluid, oxytocin, if labor is augmented, pulse, blood pressure, temperature, urine volume analysis for protein and acetone. Here, drugs given, IV fluid, pulse, here the pulse and the blood given, IV fluid, pulse, here the pulse and the blood pressure, here the temperature, here urine if protein, acetone, and volume of urine. Stage of labor. First stage of labor is the interval from the diagnosis of labor to the full dilatation of the cervix. 1-to-1 midwifery care should be provided. Additional emotional support from a birth partner should be encouraged. Obstetric and anesthetic care should be available as required. Maternal and fetal well-being should be monitored. Vaginal examinations are performed 4-hourly or as clinically indicated. Progress of labor is monitored using a partogram with timely intervention if abnormal. Partogram with timely intervention if abnormal. Appropriate pain relief should be provided consistent with the woman's wishes. Ensure adequate hydration and light diet to prevent ketosis. Second stage of labor. Urge to push. Full dilatation of the cervix and descent should be confirmed. Inspection of the perineum, vaginal examination. Adoption of other comfortable positions. More intensified maternal and fetal monitoring. Epidural analgesia, but it is delaying the second stage. Crowning indicates imminent delivery. Vaginal and perineal tears are common. Episiotomy may be done. Instrumental delivery may be needed. Effective analgesia is required by local anesthetic infiltration. Delivery of the shoulders and the body. Immediate care of neonate. Third stage of labor. Active management of third stage of labor. Active management of third stage of labor, it reduces the incidence of postpartum hemorrhage. Active management includes intramuscular injection of 10 international unit oxytocin given as delivery of the anterior shoulder occurs or immediately after delivery of the baby. Early clamping and cutting of umbilical cord. Controlled cord distraction, which is done when the signs of placental separation are seen. The placenta may not be expelled by this method in 2%. That required either repeat the controlled cord distraction after 10 minutes or manual evacuation under anesthesia or injection of oxytocin into the umbilical vein. Placental separation. Apparent lengthening of the cord. A small gush of blood from the placental bed. Raising of the uterine fundus to above the umbilicus. Uterine contractions resulting in a firm globular feel on palpation. Controlled cord distraction, as you see. This is called controlled cord distraction. One hand here above on the abdomen, the other hand on the cord, holding the cord. Holding the cord. Cord distraction. When contraction is felt, the left hand should be moved suprapubically. And the fundus elevated with palm facing toward the mother. At the same time, the right hand should grasp the cord and exert steady traction so that the placenta is separated and delivered gently. This is called controlled cord traction. Of normal labor. Spontaneous onset at 37. Spontaneous onset at 37 to 42 weeks gestation. Singleton pregnancy. Cephalic vertex presentation. No artificial interventions. Cervical dilatation of at least 1 cm every 2 hours in the active phase of first stage. Active second stage, no more than 2 hours in primiparous and 60 minutes in multiparous women. Spontaneous vaginal delivery. Third stage lasting no more than 30 minutes with active management.